Alright,
recording.
so we're going to look at iliacus, which, as we probably briefly discussed before, are the anterior stabilizers of the hip, holding the femoral head in the acetabulum that is active from mid to late stance during gait, helping to provide that posterior support. If you look into when you're intraoperatively during arthroscopy, you see the tendon running right over the front of the hip joint there on, outside the capsule, and it's very exposed in that sense right over the hip joint. So making sure that we restore its function as an anterior stabilizer of the hip is super important. And so we want to again assess its cognitive function and its automatic function. We can look and see whether the timing is more erectus femoris dominant to straight leg raise elevation, or whether iliacus fires pretty much straight away. And then we can also look at the patient's ability to cognitively activate. We also want them to be able to hold that and then co-contract their glutes, or also work with rotation. So we're going to show you how to do that. So we'll start out, we're going to use a linear transducer. Carrie's going to rest up on her elbows because it's pretty hard to activate iliacus when you're fully extended like that. And we angle the transducer parallel to the inguinal ligament and just inferior to the inguinal ligament. So we start as we pop down below the hip joint here. We come across, and this, I always like to use the femoral artery as my landmark.
Do we need to hit the lights?
So,
Sorry. Sorry. Oh, nice. Mood lighting.
so the femoral artery pulsing away here. As we apply some compression, we see the vein collapse and we see the artery pulse. So as you come up more proximally, this is where your saphenous vein comes in from where it splits greater and lesser. And you can see those two veins collapsing, but the artery staying. This is your femoral nerve over here. And then as we come a little bit lateral and we slide down, we start to see the femoral head come into play. Let's try to get a better picture. Just internally and externally rotate. There we go. That's your femoral head right there.
Can you make that image any bigger?
Yeah, I'm trying to get a better picture for
Yeah,
you.
so-
I'm sorry, it's not the best picture.
Sorry.
Okay. So this is your iliacus here. This is sartorius coming in over the top. Rectus femoris is out here, but again, it's not the clearest. Let me just change the frequency. Let's see if we can. So again, there's your femoral artery pulsing away, using that as your landmark, and then sliding laterally
That's
there.
better.
we
That's
go.
much better.
Alright, here's your iliacus sitting in here. Okay.
Oh, that's much
Here's your sartorius coming over the top, and here's your rectus femoris sitting out here. So right in here is our iliacus. Let's zoom that up. There we go.
beautiful.
Okay. So what I want you to do is just initially imagine I'm pulling your leg out of the socket, and you're going to try to suck your leg back into the socket for me. Okay, so just try to do that and relax. Okay, and that's not really initiating any iliacus contraction. There's the tendon right there. And again, just
Can you do that
try to
again?
suck back into the socket. Imagine like I'm pulling your leg out and you're trying to pull your hip back into the socket. And relax. Okay. Not getting too much going on there. This time I want you to imagine you're lifting your leg off the bed, but you're not actually going to lift your leg straight off the bed. You're just going to tense the muscles as if you're going to lift your leg off the bed. And there you see iliacus contract. And relax. Okay. And again. Good. And relax. So she's finding it with that cue. What I want to have a look at now is compare rectus femoris to iliacus. So I'm just going to get you to do an active straight leg raise for me. So just lift your leg straight off the bed. Good. And down. And relax. And again. Just lift. There we go. And down. And so iliacus looks a little delayed there to me. It's just a little slow to kick in. Rectus femoris tending to want to do more of that. Just lie back flat and see if that changes your activation pattern. Just go again for me. Just lift that leg off. And that's all rectus femoris. Okay, not much iliacus going on at all. So definitely there's a little delay and it's not a great automatic activation. What I want to see is iliacus and rectus femoris kind of coming in together to do that, because iliacus is going to stabilize that femoral head as rectus femoris lifts the leg. Alright, come back up on your elbows. And the next thing we want to do is have a look at her ability to contract that throughout range of motion. So the next thing you're going to do is you're going to imagine you're lifting the leg so that you get that little contraction of the muscle, good, and then you're going to slide your heel up towards your butt whilst you maintain the contraction, good, and then you're going to slide it back, keep that muscle contracted, and then you're going to relax. And that was very good. And that forms the first part of our rehabilitation exercise, is just getting them to contract, do a heel slide. It's very hard to just use rectus femoris when you bend the knee, and so this helps to knock out rectus femoris as part of the compensation strategy. And then the progression from that is we can work into some rotation. So what I usually get them to do is contract the muscle and then slide the heel. Stop there, keep it contracted, and do a little fallout to the side whilst you maintain the contraction. Come back in, straighten the leg, and relax. So we're starting to work with a little bit of rotation. And then from there, making it a little more difficult, going through more range, we get them to lie back supine, and we add the ball. So just pop your foot up on the ball, take this other leg out the way a little bit, and again, this is a little more difficult, so now contracting that muscle, sucking the hip into the socket, imagining you're lifting your leg, there it goes, we see it contract, and then slide your heel up towards your butt. Good, keeping that muscle contracted there, then internally rotate, then externally rotate, back to neutral, keep it contracted, slide it out, and relax it. And that's pretty tough.
Yeah,
She struggled with that, she lost it through that. But that's the next progression that I usually use in terms of trying to get iliacus going. So from there, you can do an automatic contraction in an eccentric seated position with the heels the feet fixed, leaning back into extension. And then they passively push themselves back up into flexion again, so that they're eccentrically working iliacus, coming back like that with the feet fixed on the floor. That's another way, if you can't get it going, to get some automatic contraction of it. I also like to do a little co-contraction in a sit to stand, up perched on the edge of the bed, where I get that going and they contract their glute and their iliacus together, so that they're initiating both of those together, getting a nice co-contraction, doing a sit to stand, maintaining that in the sagittal plane. So that's, for the most part, the early stage iliacus control. Progressions from there, I usually go to eccentric control in standing, where I put a TheraBand around the foot, and if the TheraBand were attached to the wall, the patient walks backwards. They then pivot
Is my TheraBand still there?
Is your TheraBand there?
I had one down
Yeah.
there for a while.
They then pivot, and then with if it's my right leg is in front, so I have not done a concentric contraction at all of the iliacus. I very slowly, eccentrically control extension. With the TheraBand, I stop, I turn around, I walk backwards again, I pivot, and I very slowly control eccentrically, coming back. And then from there, I do a little eccentric slide control with the slide board, very short range of motion. Their right foot's on the slide board and they just control into eccentric extension. You can do this on the Pilates reformer. Take them through a little bit more range of motion. They control back and forward into eccentric extension. And then, once you get to that point, you can pretty much be sure that your iliacus is working functionally to control that hip extension. You can increase the speed, you can increase the range of motion, but that's pretty much where I work through. The other thing that you want to work on though is your inner range control of your hip flexor. These patients will often lose their ability to hold up. They use their TFL instead. They use their upper fibers of their rectus femoris and their sartorius. So you want to assess for their ability to flex up, and then can they internally and externally rotate their leg. If they can't, it means that they're using TFL or some other strategy, or their adductors as a hip flexor. If they want to come up and they want to rotate, they're using their adductors. If they want to come up and internally rotate, they're using TFL. If they can't maintain that and have very free rotation, they're cheating. So I do a little active assist here where I tie some TheraBand up high, put it around their foot, and help them to come up with the assist of the TheraBand. They do a static hold. They also do a little bit of rotation to make sure they're not recruiting their TFL. They come back down. I just initially you might start with green TheraBand, then you might go to red, then you might go to yellow, and make it so that they're doing more and more active control, and then their ability to maintain that. So you really need to restore that inner range hold as well. That's more for a lumbar spine stabilizing function, bringing in some psoas as well, but that's important too. So those are the kind of key features of the iliacus and the psoas and how I progress through the rehab of those.
Sarah, can you cut? Can we go
Do that.